The rates of caesarean sections worldwide continue to rise. Currently in Canada, we are above the global rate, with 27% of all childbirths occurring via caesarean section or C-section. These statistics are alarming to women practitioners and organizations within the healthcare system. For the purposes of this project, the research question posed was, do pregnant women who undergo a caesarean section have increased risk of peripartum depression and anxiety compared with women who have a vaginal delivery? A literature review was performed using EBSCO, Google Scholar, and Athabasca University library support to identify the available literature and evidence on the chosen topic. The evidence revealed and supported a positive correlation between C-sections and peripartum depression and anxiety. A further critical appraisal was performed on 4 chosen articles. The articles were chosen based on them being the most current, most applicable to the topic, and their methods used. Critical appraisal tools were used based on their study designs to assist in identifying any strengths, barriers, limitations, and the validity of each article. The results of the critical appraisal were rather disappointing in that they did not reveal many possible interventions or strategies to combat the rising C-sections. Therefore, when determining and choosing a single intervention to discuss, another literature search and review was conducted, using EBSCO to identify any possibility of interventions. The interventions considered following the review included improving informed consent processes, strengthening shared decision-making, and providing increased education to patients, providers, and organizations on the risks and benefits on both C-sections and vaginal deliveries. Based on the amount of evidence, I chose to explore the intervention of implementing and integrating more midwives as peripartum care providers, and attempt to increase vaginal deliveries performed by midwives, and therefore decrease the rates of C-sections. This intervention was well supported, and a planning method was used consisting of 4 stages to assist in the implementation of the intervention. However, the planning method was used more from a theoretical standpoint rather than clinical. Therefore, I believe more research and planning should be performed before attempting to advocate, present, or implement more midwives successfully. There were various barriers identified throughout the research, but the largest and most consistent barrier was the low amount of professional programs for midwife training and the low numbers of practicing midwives, especially in Canada. Strategies to address this barrier were not explored for the purposes of this project. Therefore, more research and discussion is required prior to the implementation of this intervention. In closing, the rates of caesarean sections continue to rise worldwide. Unless interventions targeted at this issue are implemented in the future, the rates are predicted to continue to rise. With more planning and research, successful interventions can be implemented, and we can work towards protecting women from perinatal depression and anxiety.